Hello, this will be a short clip on how you might access and use the take list. So the take list is accessible on one of our shared drives. If you go to your PC, and this will be under the Richmond drive. It will be under the AAA take list. And it will be one of these files. As you can see, this one's active and there's a date on it from a couple of weeks ago. I have, however, opened up another file that has all the names anonymized. First of all, it will ask you for a password, which you can get while you're in AAA. But after you get past the password stage, this is typically what you would see, a large list that at the very start is typically unfiltered. You can see the bottom left-hand corner here, there's 85 patients so far in the last take period. You could see initially there's the date and the time, and you could see the first patient starts from the night shift yesterday. What you would do think in terms of managing your list initially might be change the filters, and you might only want to see the patients who are in there during the daytime. And I'll talk you through a little bit more about each column. The date and time is the date and time of referral. The list would be someone who, if they're being admitted, will be under take. And if they haven't been admitted or they are being assessed and might not be admitted, you leave them as AAA. The team, you split between day and night team. And of course, if there is a patient who hasn't been seen at the end of your day or night shift, make sure it gets converted to the subsequent shift. First name, last name, date of birth, age, gender, MRN, and NHS number would be for the specific patient. You would try to put as much relevant presenting complaint or past medical history in the next column. And we'll talk a little bit more about the plans that you might see. But typically, you would use this to communicate between the team to see what might need to be done. Where the referral source is, and whether it's been clocked, who sees the patients, and whether they've been post-ticked and where the patients are. So I'll filter a little bit more to make this more manageable. What I want to concentrate on are the ones who haven't been seen yet. So I've only selected those who haven't been clocked or those waiting to come in. So in this setting, you could see that there are a few patients not yet fully clocked. You could see a couple of patients already having clinicians next to them. This means that they have been picked up, but they're not quite been fully clocked yet. Once they have been fully clocked, you would change it to, for example, yes. And once that the patient is ready, you might do a post-take ward round. And once the post-take ward round is completed, you might put yes. For some cases, for example, cellulitis clinics or DVT clinics, sometimes there's no need for a post-take ward round and you might just put no at that point. But I want to talk you through about a few other things that you might see on the list. So sometimes there are cases that are prioritized based on clinical severity or based on time in department. As you could see here, some teams will put a TBS to be seen, number 1. This will indicate that if you were looking for a patient, this is probably the first patient to be picked up. There are other things that you might see in terms of whether someone needs a side room for infectious reasons. For example, this patient requires a side room as they have COVID positive. And this patient here may need a side room for potentially infectious diarrhea and vomiting. There's currently also important need to identify patients who are high risk for COVID, and this is typically put in by the clinician taking the referral, be it the registrar or the consultant. For example, in this patient, a nursing home resident with chest sepsis, a cough, and a high temperature. and perhaps there may be chest X-ray changes or not. And this is highlighted as high-risk COVID until we have a clear PCR swab that says otherwise. There may be also other things we want to highlight, such as whether they need ADU or HDU, or maybe an ITU review. And as you could see, sometimes it's important to leave a suggestion to what our whole team could do. For example, this patient identifies this patient needs a urine MCNS, and perhaps when they're seen, they get IV fluids. There may be even a way to highlight that a patient may need some blood tests or investigations that our nursing team could help with. For example, a repeat troponin, ideally with a specified time, and serial ECGs, ideally with a specified time as well. So the plan here is very helpful for communicating across the whole team, between doctors and nurses, and also with our flow coordinator as well. Whenever you make a change, I will emphasize it's important to press refresh so that you have the most up-to-date list. And also before you make any decisions, it's worth refreshing as well to see that you have the most up-to-date version. This is a lot to take in again. You will learn this as you go along. And please ask the team presence, and especially the AAA nurse in charge, who would know a lot of how to manage a list, or the consultant in AAA too. Thank you.